We're going to start. Welcome everybody to today's Grand Rounds. It is my pleasure to introduce a longtime friend and colleague, Dr. Brent P, who's the Chief of Division of Geriatric Psychiatry at McLean Hospital and Senior Medical Director of the Value-Based Care Solution Population Health Management at Mass General Brigham. He's an associate professor of psychiatry at the Harvard Medical School and soon to become the chair at the Tufts Department of Psychiatry. He will be speaking about his work with the based approaches to treating neuropsychiatric symptoms of dementia and population health-informed collaborative models of care. Welcome, Dr. Forster.
Thank you, Dr. Loretsky, for the kind introduction, and it's such a pleasure to be with you all today. As Helen mentioned, we've known each other a long time through our work in the American Association for Geriatric Psychiatry, and this is a topic that's long been a passion of mine from both a clinical and a research standpoint. Here are my disclosures. Helen is the current president, and I'm no longer the immediate past president, but a recent past president of AAGP. I have numerous grants from the NIA, foundations, and some pharma companies, and have consulting over the past few years with CVS and Patina Health. So I'm going to talk about the epidemiology of dementia just briefly, but what I really want to focus on today is the presentation of the behavioral symptoms of dementia, to talk about the diagnostic assessment and formulation of an evidence-based treatment program, focusing on both non-pharmacologic and evidence-based pharmacological approaches in particular. And then I want to put this in the context of the FDA warning that came out in 2005 regarding mortality with antipsychotics, talk about some of the research that we've been doing with novel therapeutics in this area, and then a bit about the work I've been doing at the population health level, in part with colleagues of yours from the Department of Medicine at UCLA. So every March, this was just a few weeks ago, the Alzheimer's Association comes out with their amazing annual facts and figures, which are always astounding to read and look at. But here are some highlights from this year. For those of you who don't do geriatric psychiatry day in and day out, it's really important to remember that we are in the midst of a growing epidemic of Alzheimer's disease, with about 6.7 million Americans today with this type of illness, with Alzheimer's type or other dementias, expected to grow to nearly 14 million by the year 2050. The cost of care is staggering. It's over $345 billion per year, 2/3 of which are paid for by our federal government, Medicare and Medicaid dollars. But there's a tremendous amount of financial and emotional toll on caregivers, with more than 11 million Americans providing unpaid care for loved ones with dementia, totaling nearly $340 billion in unpaid care, time lost to work, et cetera. The overall cost of care likely to rise to more than $1 trillion. What's not on this slide, but has been on previous year's slides, is the dramatic underdiagnosis and delay in diagnosis, especially in underserved populations in the United States. And it's the only cause of death in the top 10 where the numbers are dramatically going up in terms of mortality. So what I wanted to highlight for you all today is the problem with this illness is not just the memory loss and the functional impairment, but it really is the behavioral symptoms that drive the burden of the disease. And this is a gentleman I had originally seen when he was in his early 60s, and 6 years into his illness, he came back to me. When I first met him, he had just been going through some troubles with that year's taxes. He was an accountant for many decades, and he really was not able to do the tax returns. And he came in for an evaluation, and he was diagnosed with Alzheimer's disease, and he had some trouble with mild depression and was on mirtazapine. Now, 6 years into the illness, still following him, he started developing insomnia, irritability, especially later in the day, and physical restlessness and pacing. And for about a week, he'd been talking to these imaginary people that were in his home, and his wife thought he was more confused. This was a gentleman who was medically quite stable and was on donepezil and memantine, two standard treatments today for dementia of the Alzheimer's type, and mirtazapine at night, which he had been on for a while for anxiety and mild depression. So this case, which is relatively straightforward in this brief presentation, really highlights some of the serious questions that we need to consider as clinicians. And what I hope to do is to try to address how to approach the answer to these questions over the course of this talk. First of all, is how do you describe or even define these clusters or this constellation of neuropsychiatric symptoms? And how do you understand the causes of these symptoms, and what medical or neurological diagnoses might help explain the symptoms that this gentleman is presenting with. And if you're going to treat these symptoms, what do you want to treat in terms of targeted symptoms? How do you prioritize that? What non-pharmacological interventions may work? And if you're going to use medication, what would you choose and why? What class of drugs, which drugs, why, what's the evidence, and so forth. So what I hope to do today is think about this gentleman or think about other patients that you've seen who have neuropsychiatric symptoms in the setting of a neurodegenerative illness and think about how best to approach it. So these symptoms, for the most part, are universally present over the course of illness in somebody who has dementia or Alzheimer's or some other type of dementia. And the reason why they're important is not just the devastating impact on the emotional well-being of patients and the caregiver distress, but they also are associated with a heightened morbidity from the illness and even an increased risk of mortality. Now, if you've got an individual, maybe like this gentleman, who's got delusions or hallucinations, so psychosis in the setting of verbal or physical agitation, practice guidelines, including the APA guidelines that I'll review later on, recommend the use of atypical antipsychotics as first-line treatment for agitation when there is associated psychosis. But what about people who are agitated verbally or physically and they're not delusional? We don't really have a first-line recommendation from the experts. And in those cases, we often will combine or use individually atypical antipsychotics or maybe even mood stabilizers. So we really don't have great standards for the management of these symptoms. It is truly an individualized approach, which is what I want to convey to you all today. And up until today, April 25th, 2023, we don't have an FDA-approved medication for the treatment of agitation, psychosis, or any other behavioral symptom of dementia. That may shortly change, which I'll talk about. Our colleagues, Dilip Jesti and Sandy Finkel, first defined the psychosis of Alzheimer's disease in the DSM-4 as a research-based criteria. But the reason I have this slide up is there are a whole bunch of terms, acronyms, syndromes that are described in our literature that I think are just more confusing than not. I'll use the acronym, which some don't like, but is widely used, BPSD, standing for the behavioral and psychological symptoms of dementia. But what's most important to remember is that these symptoms represent a whole constellation of symptoms from mild anxiety and pacing and worry to physical aggression, to sexual disinhibition, to repetitive vocalizations. Anything you see in a patient who has a psychiatric illness, you could see in somebody with dementia. But the cause is quite different and the treatments may be very different. And one simple way to think about evaluating people who are presenting with behavioral symptoms in the setting of dementia is to think about the three basic buckets of causes. And I break it down into environmental, medical, and psychiatric causes. So in the environmental bucket, somebody goes into a long-term care setting. It wasn't meant for people with dementia. They're post-operative, from a hip surgery, and there's a change of shift and a lot of chaos and confusion, or there's not adequate lighting, or there may be an interaction with a care provider. All of these could trigger behavioral symptoms of some kind or another. And in every case, no matter what we do, we always have to evaluate the environmental antecedents of behavioral issues. There may be medical causes of these behavioral symptoms of dementia. It could be pain, it could be infection or constipation, electrolyte disturbance. It could be withdrawal from benzodiazepines or alcohol when someone's in a medical setting. Or it could be new medications that are prescribed or taken over the counter that have anticholinergic or other side effects that could contribute to these symptoms. And then finally, and very importantly, there's psychiatric issues antecedent to the onset of dementia. So for example, in one of the most dramatic cases I ever treated, there was a woman I was asked to see many years ago in a long-term care nursing home setting who had just spent a week in the hospital with a syncopal episode where she had passed out at home, went to the hospital, was dehydrated, given IV fluids, but she was profoundly cognitively impaired. On her imaging study showed frontal atrophy. She was diagnosed with Pick's disease, a variant of frontotemporal dementia, and she was discharged for permanent placement in a dementia unit in a nursing home. So I was asked to see this woman, and she was standing in the middle of the hallway. She had no facial expression. She was in her mid-50s. She was 30 years younger than everybody there. And when I did a brief neurological examination on her, when I shook her hand, she kind of left it up like this. I'm like, oh, this is strange. So there was nothing in the chart that mentioned any prior psychiatric history, but that could be catalepsy or a sign of catatonia. I called her husband and I asked him what was going on with his wife, and he told me that they'd been married for over 30 years. She was diagnosed with bipolar disorder in her 20s. She had been helping him raise their family. The kids were now grown up and out of the house, and she was functioning well until about 3 or 4 weeks ago, when she became despondent and apathetic and stopped eating and drinking and got dehydrated. And now they tell me she's got end-stage Pick's disease or frontotemporal dementia. And I said, well, it could be a psychiatric emergency. We'll call it catatonia, and maybe we should get this treated in a hospital setting. And sure enough, we did. And she was treated with definitive ECT therapy, and she got better. And she became my outpatient for the next 5 years. And she had mild executive dysfunction and some memory retrieval deficits at her new baseline. But I learned a lot from this case. One thing I learned was what you read in a medical record is what you read in a medical record. It's not always complete. And it may be wrong, but more often than not, it's just not the full story. And so getting collateral information is critical. Don't be afraid to re-diagnose someone if something just doesn't seem right. I'm telling this especially for those of you who are trainees here. Getting the story right is the most important thing to do in geriatric psychiatry. And then the other thing I learned was when people are in the midst of an acute psychiatric episode or crisis, whether it's psychosis or mania or depression, it's really hard to know what their cognitive baseline is. And until you know that, till you treat that psychiatric comorbidity, in this case it was catatonia, you don't really know what their underlying cognitive performance could actually be like. So our colleagues, Helen Kales and others, developed this wonderful approach called the DICE approach, which is nothing, there's no rocket science here, but it's a systematic approach describing basically what we just went over, how you would assess somebody with behavioral symptoms of dementia. So describe the symptoms, the onset, what's going on in the environment, the severity and so forth, what makes them better, what makes them worse, et cetera. Investigate the etiology, again, environmental, medical, psychiatric, et cetera, cultural, and then create a treatment plan that both involves non-pharmacologic and pharmacological interventions, and then always evaluate the outcome. And if you ask me, I want to be critical for 1 second of all of us in our field. We're not really good in psychiatry at having objective measures that we all agree upon that are gold standard to use in clinical care. Now, we have objective measures that we use in trials all the time. So for agitation, and I'll show you this in a few minutes, we have the Neuropsychiatric Inventory, which was developed by your colleague, Jeff Cummings. We have the Cohen-Mansfield Agitation Inventory. We have the Pittsburgh Agitation Scale. The list goes on and on. But do we use these in routine clinical practice? Usually not. But we need a routine approach for clinical assessment and at least some objective documentation of change of various symptoms. And by the way, these rating scales, although sometimes burdensome to use, I think are a much better way to holistically assess patients. So in terms of non-pharmacological interventions, I am giving this short shrift in this talk because the data is not as widely, it's really not, this database is not great. The studies are smaller, they're not as well controlled. There's no big pharma engine funding a lot of these trials, but there have been a number of approaches that we know work and are effective, including exercise, possibly phototherapy, certainly the way in which we support caregivers and educate them. But most importantly, we need to provide an individualized treatment approach. Every patient is different. If you've seen one person with dementia, you've seen one person with dementia. Everyone needs and deserves an individualized treatment approach when it comes to the behavioral interventions. But this is always the first step unless there's an acute safety concern that has to be addressed imminently with pharmacotherapy. Now, if we're going to need to use medications, what I'd like to do in the next few minutes is outline for you sort of a systematic approach that would be worth thinking about in terms of what drugs to use and when, and frankly, what's the evidence base for them, and then talk about our therapeutic studies with cannabinoids and ECT. I'll spend most of my time talking about the antipsychotics for two reasons. There's the most data, and they're by far the biggest controversy we have in the field of geriatric psychiatry. So this slide seems basic to those of you who've been in the field for a while, but I define psychosis here because when you think about it in older adults, I challenge you to think about it in a bit of a different way. When we talk about psychosis in a 30-year-old, we often say that Mrs. Jones has a psychotic disorder because they've got hallucinations or delusions impacting their functioning, and you're not sure which psychotic disorder it is. But that's like saying Mrs. Jones has a cough disorder, right? It could be COVID, it could be cancer, it could be allergies, it could be something stuck in their throat because they talk so much. They could be choking. honestly, there's so many causes of cough that we break it down into etiology to come up with a treatment plan. Well, we should do the same with psychosis, especially in older adults, because when we see hallucinations and delusions manifesting themselves in older adults for the first time in their life, it's usually a result of a well-defined illness that's more often than not, if they've never had a psychiatric illness, it's more often than not dementia or delirium. And we need to understand the underlying cause to really come up with an appropriate treatment plan. I know this sounds straightforward, but in busy medical settings, in hospital, general medical settings, in nursing homes, even in outpatient primary care practices, we don't often think this way. We throw a drug at a symptom, we don't think about the cause. We have to think about the cause. And when we see psychosis in people with Alzheimer's disease or other dementias, but especially in Alzheimer's, the type of psychosis or delusions is very much related to their cognitive deficits. So instead of them having bizarre delusions like an individual with schizophrenia would have, where they think there are maybe, aliens invading their eyebrows, sending them messages in the middle of the night through some satellite outside their house, that's a very bizarre, well thought out, very detailed delusions. The delusions in Alzheimer's disease are more based on the cognitive deficits. So for example, I can't remember where I put my pocketbook, so maybe someone stole it. So the delusions of theft, or the delusions of marital infidelity, or the inability to recognize familiar people or places, like Capgras syndrome. The working diagnosis always indicates how long we treat people for. So for example, if somebody's got a UTI and they develop hallucinations and they've never had a history of a psychiatric illness and they're agitated, then you may use an atypical antipsychotic for a few weeks until you treat the UTI, not with olanzapine, but with an antibiotic. But if somebody's got a longstanding history of bipolar disorder, like the woman I talked to you about before, or depression, they're likely going to need ongoing pharmacotherapy management. I'm not going to say a ton about the older drugs. So the conventional antipsychotics like chlorpromazine and haloperidol and thioridazine and perfenazine. But these medications have been studied in dementia, especially haloperidol, and they work. But the efficacy is modest, and they have substantial toxicity, which is the main reason we don't use them as first or second or third line treatments in people with dementia. There's the risk of falls. There's orthostasis, especially with the low potency antipsychotics. There's cardiac toxicity, QTc prolongation, and especially EPS and tardive dyskinesia. And as Dilip Jesti and others have taught us, when you see people who are younger on haloperidol and other conventional agents, and they go on these medications for a year, the risk of TD is about 5%. And it's about 10% after 2 years and 15% after 3 years. But now, when they're over the age of, say, 65, the TD rates go way up. So we're seeing rates of nearly a third after a year, and half of people on haloperidol over the age of 65 have tardive dyskinesia after 2 years and 2/3 after 3 years. So that's a main reason why they're not used as first-line treatments. Now, the atypical antipsychotics have become the standard of care with regards to these patients when you go through the usual workup, as we talked about, and they have psychosis associated with agitation in dementia. And the drugs on the top, the first four, have been the best studied. I'll just highlight that brexpiprazole, that had one negative and most recently the second positive trial, is currently undergoing FDA review. The FDA advisory panel just voted 9-1 about a week and a half ago to approve the drug. And the FDA's date of decision is coming up on May 10th. And if they approve it, it will be the first drug ever approved for any behavioral syndrome in dementia, and it will likely get the approval for agitation and Alzheimer's disease. So we shall see. But the risk of TD doesn't go away with the atypicals. It's still there. It's just lower and more closely approximates the risk of haloperidol in a young person. So I'm not going to go through all of the 19 or so trials that were done by pharmaceutical companies back in the 90s and early 2000s to try to develop a database, an evidence base for getting these drugs approved, which they never were, for the behavioral symptoms or the psychosis of Alzheimer's disease. But this was the first, and it outlines really some of the key points I want to make. Well, first of all, this was a drug study done in nursing homes with people who were in advanced stages of dementia, not only of the Alzheimer's type. Some had vascular dementia. People were in their mid to late 80s. They had mini-mentals in the high single digits and low teens. And the outcomes were assessed at 12 weeks. And many of these studies were 6 to 12 week studies, not 6-month or year-long studies. And the outcome measures varied widely amongst these studies. In this study, it was the Behave AD trial scale, which looks at psychosis, the subscale. And what they found was basically that at 0.5 milligram a day, there is no drug placebo separation on psychosis, but at 1 milligram and 2 milligrams a day, there's a statistically significant but clinically modest effect on reducing psychosis. But what happens when you go from 1 to 2 a day is you double the rate of extrapyramidal side effects like tremor, rigidity, shuffling gait, and so forth. So we know for risperidone, there's some kind of window, a therapeutic window of around 1 milligram to 2 milligrams, but somewhere between 1 and 2 for the average patient, the rate of EPS becomes much higher. Now, contrast that with the well-known CATIE trial, which many of you know because it was this trial that was done for people with schizophrenia, but there was also a trial done for the Alzheimer's population. Now, contrasted with the last study that I showed you, this was a study that was funded by the NIH. Its outcome was not efficacy in terms of symptom reduction. Its outcome was effectiveness, defined as how long did it take for the doctor in the study prescribing the drug to switch from drug A to drug B. And what makes people switch from drug A to drug B? Well, lack of efficacy or tolerability concerns. And so in this 9-month study, not 4 to 12 weeks or 6 to 12 weeks, it was 9 months of 421 outpatients, limited number, who were at home or assisted living, who had psychosis, aggression, or agitation in setting of Alzheimer's disease, randomized to either risperidone, olanzapine, and quetiapine at those doses versus placebo. And what you will see here is that in terms of time to switch, there was no difference. And the reason there was no difference is because placebo is a lot safer than quetiapine, olanzapine, and risperidone. But if you ask the question, was there any benefit in terms of efficacy with symptom reduction, like agitation and psychosis, there was an increased benefit with risperidone and olanzapine. Now, the quetiapine dosing was only 50 milligrams a day, which might have been a low dose. The olanzapine and risperidone doses that they achieved in this study were more like a therapeutic dose that were seen in those pharmaceutical-funded trials from the late 90s and early 2000s. Now, as I said before, placebo wins when it comes to tolerability. But if you look closely on this slide, you'll see that the death rate and the stroke risk, the CVAs, were no different drug in placebo. Now, that becomes relevant as we talk in a few minutes about the death and the stroke warnings. Another question that comes up all the time in clinical practice is, well, how long do you treat people with these drugs once people have gotten better? Because the recommendation, as you'll see in a minute from the APA, is to try to wean the drug off after 4 months if people are stable. But what Dev Devanand and colleagues showed in this New England Journal article that was published over a decade ago is that after 4 months of open label risperidone for agitation or psychosis in Alzheimer's disease, once people got better, they randomized people to stay on the drug or go to placebo. And those patients who went to placebo had a 2-fold increased risk of relapse after another 4 months went by. And then after another 4 months went by, it's a 3-fold risk. So even though, and I would still recommend that if people have never been tried off, or at least a dose reduction, we try a dose reduction, but just know it's easier said than done. And these are people who did not have a prior psychiatric history. Now, the antipsychotic medications have been associated with 2 class effects that are in warning labels. Now, the stroke risk event is not for every single antipsychotic. The mortality is a boxed warning for the entire class of atypicals and conventionals. If you look at this review paper a few years ago, more than a few years ago, about a 2 to 3-fold risk of any stroke-like event in risperidone, olanzapine, aripiprazole versus placebo, whereas with quetiapine, it's the opposite. Now, I'm not suggesting quetiapine is less likely to cause strokes, and they studied fewer people, but there seems to be a consistent reduced risk compared to the other antipsychotics of stroke and mortality in at least the data that we have with quetiapine for reasons I don't think anyone really understands. But what changed exactly 18 years ago this month was this mortality warning. And this mortality warning has changed the sort of the landscape. And this is where the controversy is, because this all was prompted by Janssen trying to get risperidone approved for the treatment of the psychosis of Alzheimer's disease. And when the FDA started to review all the data, they found the stroke risk in one of the studies. And then they did a meta-analysis with over 5,000 patients with dementia-related behavioral symptoms, 17 trials, many of the atypical antipsychotics we've already discussed versus placebo, and found a 4.5% versus 2.6% risk of death. And so one of the questions is, why are people dying on these drugs? And again, the overall risk is small, but it's statistically wildly significant because the sample size was so big. And so although we didn't have autopsy studies from these trials, the risk was likely related to either cardiac causes from QTc prolongation, presumably, and sudden cardiac death, or infection, presumably, but maybe other reasons, but presumably from sedation and maybe aspiration pneumonia. Now, the warning initially was only the atypicals, but 3 years later, the FDA broadened the warning for the entire class of both conventionals and atypicals, and it exists to this day. The APA, thankfully, came out with wonderful practice guidelines in 2016, most of which our field would agree with. This is a slide that has a lot of kind of key points on it in terms of what I already said, which was, weighing the pros and the cons and the, start low, go slow and looking at the full, cause of the illness and so forth. The only point on here I might quibble with a little bit is that number 5 is when there's an adequate response, there should be an attempt to taper and withdraw the medication within 4 months of initiating treatment, unless there's a recurrence of symptoms or there's been, a problem with recurrence with tapering before. And we know from the Dev-Devanon article that may be easier said than done. When this warning first came out, a lot of our colleagues in medicine, especially those in long-term care, like, well, what are we supposed to do? And the reality is that we need to go back to the basics of what I just talked about. Don't overreact. They had been alternatively prescribing benzodiazepines, which is not a good idea. Go through the thorough assessment of the symptoms, etiology, and employ both pharmacologic and non-pharmacological strategies. And when using antipsychotics, please give informed consent. And when faced with a distressed caregiver who's got a loved one with delusions and agitation, and you're warning them about a slight increased risk of death or stroke, I've never had a family member say, well, please don't prescribe mom olanzapine or risperidone, et cetera, because it might lead to death when she's running outside in the middle of the night and seeing things outside the window. So it's really important to do that informed consent and to weigh the safety and quality of life balance. I'm not going to dwell on the rest of the drug classes, but I'll suffice it to say with the mood stabilizing anticonvulsants, there have been quite a few divalproex studies, at least 4 randomized trials and some case series, one of which we were involved with. In 3 of the trials, the secondary outcomes were positive, but in none of the trials were the primary outcomes positive. And we know that divalproex is associated with tremor and gait disturbance and liver dysfunction and platelet dysfunction and so forth. So I think we're increasingly cautious about its use, and in some people it may help. I don't have a slide on gabapentin, but I should. There is no singular randomized controlled trial with gabapentin, but I do think there's been more widespread use because it has good anxiolytic effect. There's no drug-drug interactions with the liver enzymes, cytochrome P450 enzymes. And there's no risk of dependence or tolerance like with the benzodiazepines. But although there's case series evidence of efficacy and safety, the definitive trial has not been done, and Dev-Devanon and a few other colleagues of mine just got a poor score on a proposed NIA-funded trial, which will not be happening for gabapentin versus placebo, in part because I think the clinical practice has already been using gabapentin, but we just don't have great data, unfortunately. Our colleagues have done the landmark CITAD trial. There's also an S-CITAD trial going on right now with escitalopram. This was citalopram, not for depression and dementia, but for agitation and dementia. It was a positive trial at 10 to 30 milligrams per day on the rating scale, the neurobehavioral rating scale for agitation. What you must remember is that when using citalopram in older adults over the age of 65, there's a risk of QTc prolongation and potentially sudden cardiac death over 20 milligrams a day. So there is a dose limitation that's recommended. Why this is true, or even if it's true just for citalopram versus other SSRIs, I'm not totally sure. Let me tell you the story about our work with ECT and cannabinoids in the few remaining minutes before we entertain some questions. So one of my first jobs when I got to McLean 21 years ago was as a medical director on our inpatient dementia unit. We had this woman who had been diagnosed 10 years earlier with Alzheimer's. She's now in her late 60s, and she was violent at home with her husband. Her MRI had showed 8 years ago diffuse cortical atrophy and bilateral hippocampal atrophy. And now she was coming in with little meaningful verbal speech. And she was profoundly not only violent at home with her husband, but was really exhausting the efforts of our staff in terms of keeping people and her safe. Every attempt at medication trials either was lacking in efficacy or caused tolerability issues of sedation and gait disturbance and orthostasis. And we had no real plan for discharge. One of my colleagues, Alex Stolier, said, "What about ECT?" And I actually wondered why he would say that in somebody with advanced dementia who might have more cognitive side effects. And when you took a step back, looked at the limited literature at the time, and you wondered, well, you know what are the risks here, really? It's really a palliative intervention, and let's see what happens. So we got consent and medically cleared, and sure enough, she received 8 inpatient bilateral treatments, and her agitation aggression improvement was dramatic. She went from dozens of medications to one, went home on escitalopram only. Her tolerability was remarkable. And what's most amazing about the story, honestly, is that this woman, whose name is Louise, and her daughter Karen has been talking about her publicly for years. She's been on NPR. She's helped me in terms of future grant writing. Is that we treated this woman for a decade after this hospital stay. She remained at home for a decade with a great quality of life. She remained generally nonverbal, but she was calm and cooperative. She had participated in family events, including her daughter's wedding. And she got maintenance ECT at McLean every month for a decade before she passed away of metastatic colon cancer. Her daughter, Karen, I'm not going to read this whole thing to you, but the way she described her improvement is instead of coming at her aggressively, she reached her arms out, rubbed her cheek lovingly with a smile from ear to ear. Daughter was crying. The behaviors that were thought robbed long ago returned. She started using some words instead of gibberish. Her agitation aggression nearly disappeared. It gave my father, his wife, and me, my mother. Without ECT, she would never see me married. So one of the things that was remarkable about the story is that we started treating other people with ECT who had refractory symptoms like this woman. And the Joint Commission came to evaluate our hospital, and a very astute nurse on the Joint Commission told our CEO, who was my mentor, that you guys should really study this because you're doing some innovative things. And of course, my mentor, Bruce Cohen, said, "Brent, you should study this." And so we did. And for those of you who are interested in a research career, the best research questions come from your clinical experiences. So we started collecting data, eventually collected prospective data, a single-arm trial, collecting prospective data on people referred for ECT for this indication who were behaviorally agitated or aggressive, had failed other trials of medications, and had ECT. We started at this point with unilateral ECT. This was a sample of 23 patients published in the International Journal about 8 years ago. We saw an improvement in the Cohen-Mansfield, you can see on the right, which was significant at the 3rd treatment and continued on through the 12th treatment, with the biggest bang for your buck, if you will, by the 9th treatment. And what was amazing is these individuals had been in the hospital for nearly a full 4 weeks before they got their first treatment. So for years, we were trying to figure out how could we do a randomized trial. And just to make a long story short, the best research is collaborative research. Research is a team sport. I collaborated with my colleague, George Petrides in New York, who's an ECT researcher, and I was the Alzheimer's researcher. And we got together and we collected our friends from the Mayo Clinic in Emory and Pine Rest at Michigan State and our data coordinating center at South Carolina, and got funded to do this 5-year trial, which randomized people to unilateral brief pulse ECT versus what we were calling simulated ECT. Unfortunately, the pandemic hit at the time we were launching the study. Unfortunately, we required an investigational device exemption to get the approval to do ECT in this population from the FDA. And many people were wary of a simulated ECT arm, family members, because their loved ones had been sick for so long and just wanted active treatment. So we're just now about to get approval. We did from the FDA, we're about to get approval from the IRB to try to enhance recruitment, which has been okay, but not nearly as robust as we need it to be for really a single arm, well-controlled open label trial. Luckily, we published a lot on our methods and our pilot data. So there's a lot in the literature on what a clinician might want to think about with ECT. Finally, with cannabinoids, again, similarly from the inpatient setting, individuals non-responsive to usual treatments are having tolerability issues. And looking at the cannabinoid literature now, going back 15 years, the CB1 receptors perhaps having anxiolytic effects, and the really interesting biological effects, anti-inflammatory, anti-amyloid effects perhaps of this drug class as well. We wrote this paper a few years ago just outlining some of the mechanisms, neurotransmitter, neuroprotection, anti-inflammatory effects, and so forth of cannabinoids. And we collected data on 40 consecutive inpatients who had agitation in the setting of dementia, treated with dronabinol with a mean dose of 7 milligrams a day. We saw a significant, really substantially significant pre-post difference on the Pittsburgh Agitation Scale. And this led to our 5-year R01 that's now in year 7. We've got a year to go. We've recruited 63 of the 80 patients, looking at the efficacy and safety of 5 milligrams BID of dronabinol versus placebo, now being conducted in inpatient, outpatient, and long-term care settings in Miami with Dr. Mark Gronin, Paul Rosenberg at Hopkins, and I'm up at McLean, and our colleagues at the North Shore Medical Center. This is the algorithm for treatment, and we have rescue medication with lorazepam and trazodone, and we're excluding people who are severely unstable medically or have seizure history because of the risk of seizures with cannabinoids, and of course, people who are currently delirious. So hopefully we'll have results of the study soon, but if the first 58 patients, these were the demographic profile, again, 65% women, highly educated sample. Interestingly, if you look on the right, this was not a health, the fair and poor was substantial. 30 to 40% of these folks rate their health as fair or poor. These are not medically, they're medically stable, but they have substantial medical comorbidity as well. So it's going to be a very generalizable population. We're also doing a study at McLean with my colleague Stacy Gruber, looking at a liquid preparation of cannabidiol, a CBD product. The other one was THC, synthetic. This is a natural plant-based cannabidiol preparation with predominantly CBD, very little THC. And we're looking at, and remember, when you have a plant-based product, it's a full spectrum product. So there are other cannabinoids as well besides CBD and THC. The last thing is just a few reminders. Benzodiazepines like lorazepam are problematic in older adults for so many reasons. Most of them are listed here. Efficacy issues, safety issues, risk of dependence issues and withdrawal, the rare paradoxical disinhibition. But the main issue is that they may work for a little bit of time and they may be the go-to drug for some non-psychiatric specialists, and then getting people off can be very, very challenging. And don't forget that the neuropsychiatric effects of cholinergic agents and also potentially memantine, that these cholinergic drugs like rivastigmine, I should say in particular, may benefit those with Lewy body dementia who have visual hallucinations because these drugs work pretty well over time in reducing visual hallucinations and possibly also apathy. And then this is I'm going to have one more section of this talk for a couple minutes, but I just wanted to give you 4 clinical scenarios and how clinicians might want to think about pharmacotherapy approaches based on the syndrome that they're being presented with. If you've got somebody with dementia who's mildly anxious and pacing, but they're not physically aggressive and they don't have psychosis and it's episodic, we often will use trazodone as needed, even though there's not great efficacy. We might use an SSRI based on the citalopram study, or mirtazapine if there's sleep disturbance or appetite changes and anxiety along with nonspecific agitation. If on the other side of the spectrum, they're clearly delusional or have hallucinations and they have agitation or aggression, that's where the experts would recommend, after the usual workup and non-pharm interventions, an atypical antipsychotic medication like risperidone, olanzapine, quetiapine, or maybe even brexpiprazole one day. If they have aggression, agitation with depression, we often will recommend an antidepressant. The problem is the 4th category, and these are the ones that we see in the specialty world. These folks are physically or verbally aggressive or agitated. They do not have psychosis, and this is where we often use mood stabilizing anticonvulsants. We may use atypical antipsychotics. We may combine those. We may also combine them with SSRIs. This is a tricky group. These are the folks that often wind up in the hospital. These are the ones that require a lot of attention in the long-term care setting. This may be a group where the cannabinoids will have some evidence for efficacy and safety. I didn't mention this, but nabilone, which is a synthetic THC product available in Canada, has been shown by Krista Langto to have efficacy for agitation and dementia. And the final thing I just want to mention is that those of us in psychiatry, and in geriatric psychiatry in particular, have an amazing opportunity to be part of the transformation of healthcare that we're witnessing in front of our eyes. In yesterday's healthcare, which unfortunately is today's healthcare in many places, We build care around the hospital or the institution. We live in a fee-for-service world. By the more we do, the more we get paid, like procedures or hospitalizations. And we're responsible for the immediate outcome of patients over a few days or a week or two. And we grudgingly accept or did accept these dramatic escalations in healthcare costs. But when we think about a term that some call value-based care, the population health approaches to holistic care, we build the care not around the institution, but around the patient. We look for incentivizing better quality care as opposed to just more care. And we're no longer responsible just for the immediate outcomes, but for the whole ongoing health of the patient. And we cannot possibly sustain the dramatic increase in healthcare costs. And I would argue, and I've made this argument before in a paper I wrote and a talk that I gave at the AGP a few years ago, that we have an opportunity in geriatric psychiatry to be a leader in this evolving population health-based landscape. And just using Alzheimer's disease as an example, you could use depression if you want. That's like collaborative care models. That's what I'm talking about now for dementia. And your colleague, David Rubin at UCLA, has been a real pioneer in this. But there are population health approaches. I'll mention two in a minute. They really put us at the epicenter of new ways to really improve the quality of care and reduce overall costs of care for people with complex illnesses like dementia. So David Rubin and colleagues at UCLA developed the ADC model, the Alzheimer's dementia care model, and we were part of his Hartford Foundation funded study where we launched this in the winter of 2020, really good timing, but we were able to make it a virtual offering initially, and now it's a hybrid offering, pairing a social worker, a geriatric NP, and a supervising geriatrician to care for a population of patients being cared for in primary care with neurocognitive disorders, looking at diagnostic assessment and diagnostic disclosure, reducing behavioral symptoms of dementia, supporting caregivers, navigating resources in the community, and very importantly, managing pharmacologically, including deprescribing unnecessary medications. This has been widely well received by our primary care colleagues who find this to be helpful, non-burdensome, takes away a lot of their stress about managing this population, and it's been successful in evidence-based data that David and others have worked on in reducing ED visits and cost of care. We also recognize that it's kind of an expensive intervention, and there's way too many people with dementia, and this is really probably geared more for people who have more moderate to advanced risk of hospitalization, nursing home placement because of behavioral symptoms or stage of illness. So we then got a grant from the NIA Impact Laboratory to study the care ecosystem model, which in our hands we call Crescent. And instead of a non-clinician care navigator, we trained our existing nurse care managers to deliver these 7 evidence-based care protocols, sort of, if you will, gold standard dementia care in collaboration with nurses, or these were the nurses in collaboration with the rest of the team, the primary care clinician, and the very close linkage with the patient and their family. And we saw a tremendous uptake of the utilization of these protocols by the nurses who were in our intervention arm versus our control arm. We published a paper on this last winter, and we have another one that's in the works as well. So I think that in summary, really what I wanted to get across to those of you who are going to be doing a lot of clinical care of older adults is to remember that behavioral symptoms of dementia are not a diagnosis unto themselves. They are symptoms or syndromes caused by specific etiologies. They could be medical, psychiatric, environmental, or some combination. And it's our job to do a complete assessment, unless, of course, we have to intervene acutely for safety purposes. But even then, we still need to know the cause. We always want to use non-pharmacological interventions in every case. And the working diagnosis really determines our management approach: short intervention, longer intervention, which treatments to use, and so forth. We always have to weigh pros and cons with tolerability. And at the end of the day, what our caregivers say they want and what our patients want, and frankly, what we want, is safety and quality of life. And balancing those two is challenging, but that really becomes a defining and grounding way to approach conversations, difficult conversations with patients and their loved ones. And I want you to remember that there are these evidence-based models of care that I think we can all play a role on in psychiatry and really be part of the solution to some of the psychiatric complications of medical illness, as well as more sort of holistic approaches, and in this case, holistic approaches to the care of people with dementia. So I'm going to stop there and thank you so much for your attention. And I welcome sort of any and all, comments that you may have.
Okay, thank you so much, Brent, for this comprehensive talk. We have a couple of questions from Walter Dunn. What is your opinion about establishing FDA-approved treatments for specific type of dementia-related psychosis agitation versus psychosis agitation secondary to any type of dementia? Pimavanserin application was for an FDA label for psychosis secondary to any type of dementia. The FDA did not approve. Conversely, the current brexpiprazole application is for agitation secondary to dementia, to Alzheimer's. The underlying question is whether the mechanism of psychosis and agitation across the different dementias is specific enough such that antipsychotics should be studied in individual dementias. Conversely, is the agitation and psychosis in the dementias a common outcome that can be responsive to antipsychotics, irrespective of the upstream neurodegenerative mechanisms?
So Helen, first of all, I heard you perfectly. I look like I'm frozen, but you can hear me okay, right?
Yes, it's all good.
So that was a wonderful question and a complicated one, but let me just simplify it a little bit, because I think one thing I've learned in doing research and providing clinical care is that the patients that you're treating in front of you may not match up with what's been done in the literature with a given study. And so in some ways, your question gets to this. So for pimavanserin, for example, it was approved for the psychosis in Parkinson's disease. That's a very specific condition with a very specific potential pathophysiology, and there's data to support its efficacy. But when you start looking at that in another type of neurodegenerative disorder, there was no evidence of efficacy. So I think it's really important. So for example, with brexpiprazole, there was a lot of back and forth with the FDA about whether it's, should be given an indication for the spectrum of dementia or only in Alzheimer's disease. At the end of the day, from a mechanism standpoint, we don't really know. We have a lot of theories about what is the mechanism, what is the pathophysiological mechanism of, let's say, psychosis in Alzheimer's disease, or psychosis in FTD, or psychosis in vascular dementia. We don't really understand this terribly well. We're basically repurposing drugs that were developed for psychiatric illnesses where we also don't understand mechanism terribly well. So instead of, the way I think about this as a clinician is I worry less about mechanism and I worry more about what did the trials show in terms of safety and efficacy in that patient population, defined as it was in that study. So again, was this studied in a mixed population with Alzheimer's and vascular? Was it just Alzheimer's? Knowing, of course, it was a clinical diagnosis. This is also true, by the way, with the cholinesterase inhibitors and memantine. And because of the, this widespread use of those drugs in all dementias, except for frontotemporal dementia, the main reason is because those trials were negative. And there were positive trials in Alzheimer's disease and some positive trials in mixed dementias. So, and some positive trials in Parkinson's dementia. And one of those drugs has the indications. So I know that was a long-winded answer, but it was a really great question. I guess the bottom line for me is, what do the trials look like? Who are they studying? Does that look like the patient who's in front of you? And at the end of the day, you're dealing with an N of 1 in a clinical situation, and you're always weighing the pros and cons. And just because a study showed one thing doesn't mean your patient's going to react in the same way.
Yes, the next question is about lamotrigine use in this population.
Excellent question. So I had a lot of experience with my career development award using lamotrigine in older adults with bipolar depression. I think it's an extraordinarily well-tolerated drug in older adults when it's used correctly and dosed correctly. I don't know of any data, though, on the use of lamotrigine for behavioral symptoms of dementia, agitation in particular. I think there's good rationale that it might be effective. The problem is dosing. As you all know, you've got to titrate to a therapeutic dose very gradually over weeks. And to get people to a tolerable dose, that's going to, or get someone to an efficacious dose that's going to be well tolerated in terms of risk of Stevens-Johnson syndrome, it's going to take a while. And you may not have a while in terms of your need to reduce symptoms more acutely. So that's sort of my big picture thinking about lamotrigine.
Okay, so we have 2 comments and questions. Pauline wants to know, great talk, exciting times in dementia care. Why is lorazepam used as a rescue medication in the clinical trials for behavioral disturbances when clinically benzos should be avoided?
That is an amazing question. I think, honestly, we talked about this a lot. It has been, in some ways, the historical go-to rescue medication when you're exposing people to placebo, because you know a few doses or a single dose might be effective. This is not long-term use of benzodiazepines. And honestly, if there was another, like we also use trazodone, and frankly, preferentially, we'll use trazodone. We don't have a lot of other good alternatives. And the issue here was when we first designed the trial, it was an inpatient study with very agitated patients who might be of safety concern. And we wanted to make sure that the clinicians had something to use that might have an acute effect and limit the dropout. I agree wholeheartedly, this is not ideal. And I would welcome other ideas beyond trazodone for rescue medication in these types of trials.
Can you speak about low dose clozapine use?
In our unofficial algorithm that we would be using when I was doing a lot of this work on the inpatient setting, I still do a lot of this in the long-term care setting. Clozapine was sometimes used after the other atypical antipsychotics had failed, after anticonvulsants had failed, after combination therapy had failed. Question is, do you go to that first or ECT? I think it's something to consider, especially in patients who have psychosis in the setting of a Parkinsonian type of dementia, where you're maybe likely not going to exacerbate Parkinsonism. So, for example, in Parkinson's disease psychosis, again, this is before pimavanserin was available. I think its use is complicated by the usual side effects of clozapine, but especially the anticholinergic side effects in a drug, using a drug with anticholinergic toxicity in a condition that's an anticholinergic disease. It's basically a cholinergic deprived disease, dementia. So that worries me as well. And there's very limited data. So I would say, maybe fourth, fifth step after other things you've tried. But I might consider ECT before clozapine unless there's a Parkinsonian type of dementia, nothing else has worked.
Here's a comment to respond to you about low dose mirtazapine use as a rescue medication, like 3.75 milligrams. Instead of
really interesting idea. I've never used mirtazapine lower than 7.5. As you probably know, it's more sedating and antihistaminic at lower doses and less so at higher doses for reasons I've never fully understood. It's an interesting idea. I've never tried mirtazapine as a PRN medication. I'm not aware that it's used widely in clinical practice as a PRN medication, but in this situation, it's an interesting thought. I'd be curious to talk with others about their thoughts on that at some point.
Okay. And we have a good comment from Brandon Yarns. Brent, thank you so much for the wonderful presentation. If brexpiprazole is granted FDA approval, do you predict it will be used widespread first line for all sorts of agitation? Would you modify your clinical algorithm for patients with agitation where you distinguish agitation from anxiety or depression, or would you recommend just using it across the board for agitation and psychosis? I would also add another element of this. Once it's approved, what's going to happen to the CMS discouragement of nursing homes for using psychotropic neuroleptic medications for management of behaviors?
So I don't have a crystal ball, but I do have some thoughts on this question, Brandon. Thank you for the excellent question, and Helen. Couple thoughts. First of all, remember, there are at least 4 other atypical antipsychotics that have multiple positive efficacy outcomes in clinical trials for agitation and psychosis and dementia. Risperidone has 5, olanzapine has about 4, aripiprazole has 3. There are efficacy trials that have demonstrated beneficial outcomes, though we've known that for 24 years since that first 1999 study came out. And the FDA has not approved these drugs, not because of lack of efficacy, but because of a concern of tolerability. And the question here is, why would they approve this drug now unless there's some sort of tolerability advantage, and not approve the others? So I don't know the answer to that question, but that's one question I have in my mind. So one of the barriers to using brexpiprazole, if it is approved in clinical settings, is going to be twofold. Cost. All right, this is not going to be a generically available drug. It's going to be very expensive. It's going to require prior authorization and failed other trials. So by definition, unless someone's willing to pay out of pocket an extraordinary amount of money, this won't be first line treatment recommendations, because we won't be allowed to use it first line. And again, unless I'm missing something here. So there's going to be a PA barrier, a prior authorization barrier and a cost barrier. To get to your question, and by the way, Brandon, you asked also about different types of dementias. It's gonna, if it gets approved, have the indication for agitation and Alzheimer's disease. But their studies also included other types of dementias. And you could imagine it being more widespread use. But there you may run into a problem. If you don't have a clinical diagnosis that can be substantiated, it may prevent you getting prior authorization approval for the use of it in the non-Alzheimer's population. It's going to be very interesting what happens. But the second issue you raised, Helen, is also really interesting. To let people know what Helen's talking about, if you're a patient, if you're a doctor working in a nursing home setting with somebody who's got psychosis of Alzheimer's disease, you're told how to prescribe antipsychotic drugs. And the reason you're told how to do them is because of the star rating system that exists by Medicare, such that there's a formula. And the rating is really with a numerator of number of antipsychotic prescriptions over number of patients. And they exclude from the denominator 3 clinical conditions: schizophrenia, Tourette's, and Huntington's. But if you've got Alzheimer's associated psychosis, you're in the denominator, and you're discouraged from using antipsychotics in that population. By the way, you're discouraged from using it if you got psychotic depression or bipolar disorder with manic features as well, for unclear reasons. But if I'm a doctor working in a memory care outpatient, assisted living facility or an outpatient clinic, nobody's telling me what to do with medication prescribing. There's a financial disincentive. Really, the star ratings come down to finances, a financial disincentive from using antipsychotics for appropriate use in nursing homes, which is a huge issue that Helen, I, and others have been tackling from a policy standpoint. So Helen, I actually don't think it's going to change anything about the use of antipsychotics in long-term care settings unless CMS decides to change their criteria for what they're calling inappropriate use and change it to the recommendations by many of us for what's called appropriate use. And there's really good, white papers that have been written on what really reasonable appropriate use criteria should look like that, frankly, are supported by the APA guidelines and so forth. So I actually don't think there'll be any change unless Medicare rethinks this whole situation.
Okay, we are out of time. Unfortunately, there are some questions I'm trying to answer, like if maybe briefly, psilocybin use. There's not much data on it.
No, there's not. And there only, I know of one study that Hopkins, Paul Rosenberg and colleagues are doing with depression and dementia that's really worth following. I think probably for agitation and psychosis, again, who knows, but it could very well make things worse.
It was an amazing talk and presentation. Thank you to everybody who attended and asked questions. And thank you to Brent for coming and presenting.
Thank you, guys. It was my pleasure and honor to be here today.
Thank you.